stimulate, and we want recovery within 5 minutes. If it's not within 5 minutes, I've given them too long of a time on the activity, I've asked them to move their head too fast, I've given them some type of stimulation that's made them sick. So I want them to recover, because I want them to learn that if they go start getting dizziness, that they recover quickly from it. That's the key. So how does the patient cope or recover from the increased symptoms? They assume a no pain, no gain for these patients. That does not work in head injury population. It may work with physical therapy and things like that for exercise and strength training. It does not work for vestibular rehabilitation. So we're going to look at visual vestibular guidance, consider substitution and habituation, head movement versus visual motion, looking at blinking, central peripheral awareness. Those are the things we've been talking about. Lenses, looking at removal of generally all progressives, maybe have a bifocal, maybe go to multiple pairs. So one of our examples too is that a lot of times our patients may come in with monovision and they want to be in monovision. We actually have to take them out of monovision and do rehabilitation first, and then once they're stable, we may consider them going back to monovision. Low plus again is a very valuable tool, or cut minus in your prescription. Now let's talk about if I have a patient who refracts out at plus 50, and the patient says, I don't want to wear glasses, so can I get contact lenses? So if I give the patient plus 50 contacts versus plus, is there a difference in magnification? Yes. Lenses will give you magnification, contacts generally not. So you cannot give these patients contacts and be successful. You have to leave them in lenses, which will give them a magnification factor. So be careful about that. One other thing that generally we can come up with every once in a while, but not very often, thank goodness, is anisoconia. Differences in image size can be a factor as well. So, optometric management, we're going to look at stabilizing binocular issues. If you've got diplopia, address that. You may use compensatory prism, you could be using therapy depending on the patient. In my office, we had this thing, one of our residents, the resident comes to Dr. Backstrom, should I go and use a base-in prism or should I use binasal occlusion? What is my answer? It depends. That's my black and white answer. It comes out every time, works perfect. I got a perfect answer, okay? But the reason is that some patients may need one or another one. So again, always remember, you've got options and tools. You have a toolbox with lots of tools. You've got to decide which ones are most appropriate for each case. Selective occlusion using binasals or pinhole glasses. And we'll also make sure we address basic binocular and visual skills, not just orthoptics, but when we're working in therapy, we want them to be aware of peripheral inputs so you get a fast recovery of fusion, and then stereo on top of that. So watch what we're doing. Sometimes when we're doing therapy, let's say we're doing saccadic therapy, look what's in the background. See all the noise in the background? So I would never start a patient doing saccade therapy with something like this, because this is too much information. I use here a little bit of a white background. Why? When they're making the eye movement back and forth, much more comfortable initially, and then we may add some distractors in the periphery over time. So be careful of what you're doing. Now, key points in treatment, you have spontaneous adaptation. Some of these patients just get better faster. Usually they get better if they're moving. If they're in bed, symptomatic, and not moving at all, not likely to recover as quickly. Gaze stabilization needs movement to recover. That means we need to add head movement with visual fixation. We're going to look at the gain of VOR needs to be about 1. So we're going to add either lenses, we may add vision therapy for the oculomotor skills to be improved. Again, we must learn to control symptoms. So these patients can now get used to feeling better all the time instead of feeling worse. All right, let's give you some examples. Compensatory, eliminate the condition. So let's say you get dizzy when you move your head. I got the perfect answer. Stop moving. Don't get up, stay in bed. We don't want that, do we? We want our patients to be active and return to life. But that's a compensatory strategy. Substitution and guidance. What other input can they include to allow them to be more comfortable? That includes fixation, blinking, when they're walking and turning, making movements less complex. Habituation therapy, we can use that. We can also use lenses and prisms, sector occlusion, and also basic vision skills therapy. So this example, the picture we showed earlier, again with spot occlusion. This was a patient who actually had poor fusion illness. When they were looking, we would add prism into the prescription, line it up, keep going, and as soon as they got it lined up, they lost fixation. You would reduce it, boom. So what happens is that the patient, we could not find any prism that allowed fusion. So you can use a spot patch to occlude centrally and allow peripheral input for balance. Again, pinhole glasses we mentioned earlier today too. Now, substitution motor. Again, we've been talking about touching the wall or touching